Thank you, everyone, for the opportunity to join this evening. The Health Department is always eager and enthusiastic to engage members of the community, and tonight's no exception. So thank you for allowing me to join this evening's observance. So as mentioned, my name is Adrian Guzman. I'm the Director of Policy and External Affairs for the Health Department's Bureau of Hepatitis, HIV, and STIs. And that means I oversee the Bureau's local, state, and federal legislative, regulatory, and policy advocacy related to HIV, STIs, and viral hepatitis. And then the drama major comes in handy because I also oversee our media and public relations. When I was talking to Rabbi James earlier in the week, she suggested that I share how I came to this work, and it took me a minute. A decade and a half into my career, it's difficult to imagine a time when I wasn't involved in HIV law and policy. It's even more difficult to try to recall what brought me to the work. So I gave it some thought, and I think the moment that sparked my interest in HIV policy, which, by the way, was the first moment I even knew what HIV policy was a thing. It was a guest lecture by Terry McGovern, who founded the HIV Law Project here in New York City. This was during maybe the second or third week of my first semester of public health school, and I remember Terry McGovern sharing the story of a young Latina woman who lived on the Lower East Side. And this was back in 1989, and around that time she tested positive for HIV. And later that year, she applied for Supplemental Security Income, or SSI, benefits. She was experiencing painful bouts of pelvic inflammatory disease, chronic pelvic pain, constant burning in the uterus and vagina, recurring fever and nausea, an ovarian cyst, severe anemia, cervical lesions, and a T-cell count in the 200 to 300 range. So upon reviewing her application for benefits, the Social Security Administration classified her as HIV positive, but as asymptomatic, and thus denied her claim. So how could a person exhibiting these symptoms, these medically documented symptoms, be deemed asymptomatic? So at the time, the Social Security Administration based these decisions on the current CDC definition of AIDS, which, of course, had been based on CDC surveillance data on the disease, which, of course, had occurred almost entirely among young, white, gay men. So the CDC's definition of AIDS excluded most infections specific to women. So Terry McGovern argued that relying on that narrow definition to determine benefit eligibility was discriminatory and violated the U.S. Constitution's Equal Protection Clause. And we'd be here all night. I could explain every stage of the litigation, but long story short, and 3 years later, they won. And the victory and the subsequent activism by a coalition of local and national HIV organizations helped to secure even broader policy wins. So the CDC expanded its definition of AIDS, and the Social Security Administration updated its listing for how they evaluated HIV infection. So now, HIV infection actually includes conditions common to women. And there's a new catch-all section enabling anyone with a serious HIV-related condition with documented symptoms to qualify for benefits. So it's this idea that maybe besides abortion and abortion-related services, there's no other health condition, no other health issue that's as regulated by the government, as closely watched by the government, as politicized by the government as HIV. And that's what really drew me to the work. It's this really fascinating intersection between the law and public health. It seems odd, it seems strange that women with HIV experiencing severe HIV-related symptoms and conditions were denied life-saving benefits as recently as the early 1990s. But as sort of been mentioned earlier this evening, remember, the government's response to the early AIDS epidemic was a shameful one. Investment in research and in the programming and services needed to stem the spread of the virus came so slowly and were so woefully underfunded and inadequate. Now, AIDS activism, much of it based here in New York City, was born of this willful inaction. Many of you may remember, New Yorkers took to the streets, they protested, they demonstrated, they marched, they demanded, they took to public parks and churches and Wall Street and to the steps of City Hall and to the steps of the health department, and they took to the courts, just like Terry McGovern did, and they refused to let their government stand idly by as their loved ones suffered the devastating effects of the virus. So activism is why the government began to pay attention. Activism is what brought about safe and effective antiretroviral treatment that allows people with HIV to become virally suppressed and not pass HIV to others through sex. Activism is what brought about pre-exposure prophylaxis, or PrEP, a medicine that HIV-negative people can take to protect themselves against HIV infection. Activism is what compelled Congress to create the Ryan White HIV/AIDS program. Through this federal legislation, it allows people with HIV to have access to the medical and supportive services they need to be healthy and to thrive. And activism is why, in 2023, new HIV diagnoses here in New York City were down more than 71% compared with 2001, when we began collecting these data. And on Monday, on World AIDS Day, the Health Department will release our 2024 data and give a snapshot of where we are in our efforts to end HIV here in the city. So activism is responsible for all these things, and I hope, it is our hope that activism will get us through what we're going through today. So bear with me. Since his inauguration in January, President Donald Trump has signed over 200 executive orders directing action on a range of issues, including issues affecting communities most vulnerable to HIV, including people of color, immigrants, transgender people. In March, U.S. Department of Health and Human Services, HHS Secretary Robert F. Kennedy Jr. announced an agency-wide restructuring, which included a proposal to slash HHS staff by nearly 25%, including firing 2,400 people in the CDC alone. And in July, President Trump signed Budget Reconciliation H.R. 1, one big, beautiful bill, into law, and that ushered in sweeping changes to Medicaid and other safety net programs, including the largest Medicaid funding cut in history, and restrictions in Medicaid and SNAP eligibility and coverage. So remember, Medicaid is in fact the largest source of insurance coverage for people with HIV. Something like 40% of all people with HIV under the age of 65 are covered by Medicaid. So under H.R. 1, which guts Medicaid funding and the whole infrastructure, more burdensome reporting requirements, more frequent eligibility redeterminations, and other provisions that will present barriers to enrollment and recertification. All of that will be more and particularly harmful to people with HIV. And remember, loss of coverage, even if temporary, can interrupt access to HIV treatment, complicating viral suppression and the effectiveness of subsequent treatment regimens. So last month, at last count, I think it was a 43-day federal budget shutdown, which, by the way, is the longest in U.S. history. Second longest occurred during President Trump's first term. The president did sign a continuing resolution to temporarily fund the government while Congress continues its work to finalize its fiscal year 2026 appropriations bills, which, by the way, were due October 1st, 2025. So somehow, the president, the House of Representatives, and the Senate have to agree on funding levels for all federal agencies and their programs, including HIV programs. Now, based on the proposals that they released earlier this year, that won't be easy. So the Senate, somehow, remarkably, proposed no cuts to major funding streams for HIV. But the president and the House proposed to fully eliminate $755.6 million in CDC funding for HIV prevention, completely zero out all federal funding to prevent HIV. Now, if these cuts make it into the final budget, New York City will see roughly $41 million cut in funding. Now, this funding currently supports a number of our critical HIV activities. This is the funding we use to identify people newly diagnosed with HIV, to engage them, to link them to care, and to offer partner services so they can have support in communicating to their partners that they just tested positive for HIV. This funding supports our collection of HIV data, our reporting of the data. It supports our efforts to routinize HIV testing in hospitals and clinics, and also to expand non-traditional settings when it comes to HIV testing, in health fairs, in faith-based institutions, all sorts of settings that we are able to reach people who might not traditionally engage in the traditional healthcare system. This funding also supports our HIV testing and navigation support for HIV PrEP and emergency post-exposure prophylaxis and HIV treatment at the city's sexual health clinics. This funding supports our distribution of condoms and other safer sex products, and this funding supports our Placeholder Network 2.0. This is our flagship program, our coalition of 18 agencies across the city funded to provide HIV and sexual health services and conducting outreach focusing on communities most vulnerable to HIV. So cuts to federal funding on this scale, especially as H.R. 1 is rolled out and more Medicaid enrollees are expected to lose coverage, will result in less access to HIV testing, treatment, and prevention, less access to health insurance and safety net programs, increased healthcare costs and health systems costs, fewer people knowing their HIV status, increased HIV transmission, and more AIDS-related deaths. So none of that is an exaggeration. This isn't the drama major coming into play here. I'm not dressing this up. These are facts. These are evidence-based facts that what will happen if we lose tens of millions of dollars in HIV funding to prevent HIV. And if it comes across as alarmist, it's because we need to raise alarms about these proposed cuts and how they roll back decades of hard-won progress toward bringing down new HIV diagnoses and improving the health and well-being of people with HIV. So lastly, we're doing all we can. We're knocking on members of Congress's doors. We are advocating with City Hall. We're doing all we can to protect this funding. But as a government agency, we are, of course, limited in what we can say or do with regard to funding and other policy matters. However, we can be creative and educate the public about what they can do. So if you're interested in learning more about the importance of federal funding for HIV, check out Save HIV Funding campaign at savehivfunding.org. This is a campaign driven by all sorts of advocates and activists that are doing incredible work educating people about these issues and what can happen if we don't continue to sustain funding for the ending the HIV epidemic work and to protect the health and safety of people with HIV. So if I can leave you with one thought, it's that there is no public health without activism. We should never let the lessons of the early AIDS epidemic be lost or be taken for granted, not only in our HIV efforts, but in any public health crisis that comes our way. So be sure to engage others, spread the word, talk to your elected and other government officials, and impress upon them the importance of sustaining this important work. And again, thank you for the opportunity to join. I really enjoyed the evening, and I hope that you can take this information and spread the word. So thank you again for the opportunity to share. Thank you.